Invite the next speaker, Dr. Gazal PATNAIK. For those of you who do not know who she is my associate working with me. She joined me after after completing her fellowship at Shankar Netralaya. An excellent ophthalmologist, very good surgeon. Very proud to have her with me. And she speaks on flax in the presence of a small pupil. Over to you, Gazal.
A very good morning, everyone. Thank you, Dr. Mishra, for giving me this platform, and thank you, Dr. Krishna, for laying down the groundwork for me. So before going into flax in small pupil, let's first understand the challenges we face for any cataract surgery in small pupil. So it begins with the first step of making a rhexis. In any small pupil, the zonules are expected to be weaker. The rhexis, there is always a chance of runaway. Also, we tend to make a smaller rhexis when the dilatation is poor. So the next thing is coming to the nucleus emulsification part, nucleus fragmentation part. In that case, as we can see here, the risk of iris damage is too high at every step. Also, getting a piece from under the iris surface, it's very risky. Also, you can catch hold of any tissue that is nearby. And by the time we reach at the cortical removal step, it's kind of a blind procedure. Any beginner will face difficulty here going down, and there chances of complications like zonule dehiscence, bag dehiscence is quite common. So in short, it revolves around rhexis formation and visualization part, which kind of decreases with every step, with every minute. Like in small pupil, nucleus fragmentation and emulsification takes the maximum time, where the fluidics as well as the side instrument damages the iris pupils, iris sphincters, and the pupil size kind of gradually decreases. So does flax has a role in that in small pupil? Let's understand this. So first, a normal case where you can see the pupil is well dilated, you can have a rhexis of around 5.5, and as demonstrated earlier by earlier speaker, the rhexis and the nucleotomy is done, and after that it is just a piece of cake like any other routine cases. Also here, as you can see, comparison between a normal dilatation pupil where you can get a 5.5 mm of rhexis, and in little bit smaller you can get a 5.3. Similarly, if you have a much smaller pupil, you can even customize to 4.7 mm of rhexis margin, which you can see is quite well centered in an irregularly dilated pupil where you have different iris atrophic patches. After that, you just have to take out the loosened up capsule rhexis, and then the nucleus fragments as described is already softened. So you just have to take each pieces away. So here, once the docking is done in the solid lens access platform, sorry, I'm not able to move the video. Yeah, no, just
She's saying she's not able
not
to
able
fast
to speed
forward
it up. Yeah. So once it is done, you can see the parameters that is been shown. So you can customize it according to the pupil size you get. So you, if you get this type of pupil size, you can customize it to 4.7, and then lens chop what area you want to chop the lens, and then with the help of the cursor you can move the particular region where you want the laser to be emitted and the cuts to be formed, both corneal as well as the nucleus part. So here the 4.7 mm flax patient, as you can see, The nucleotomy part, you need not go under the iris merge. Pupil size, the dilatation of the pupil at the end of the flax is well maintained. The rhexis is done, and just you have to separate the lens pieces and take it out in the center and eat it up. So we did a comparison of flax with the conventional phaco in eyes with small pupil. So we did for a moderate grade of cataract from 2 to 3 grade LOCS3 with maximum pupil size we took as 6 millimeters, and all went the same dilatation and flax and the cataract removal procedure by a single ophthalmologist. All other retinal and co-ocular disorders were excluded. And we took 25 eyes of 25 patients. We did all the specular thing after the flax was done to understand if there is any corneal damage also after the laser emission. We took into consideration the suction on time as well as the transfer time, and we compared both the baseline parameters in both the groups. And what we found here is the endothelial cell count, the change in endothelial cell count is quite correlating with the ultrasonic time, the total phaco time and cumulative dissipated energy, which is quite higher in cases of a conventional phaco as compared to flax. Also, there was a case of posterior capsular rupture in the conventional group. So coming to the historical part, femto when it started, it was mainly for the Fuchs dystrophy, where it minimizes the endothelial cell loss, which was taken care as a greater importance. Also, they pointed out that it has a limited scope, especially in small pupils, and they said that flax will be useful in complex cases like this, and they excluded small pupils. However, if we go to the understanding pathophysiology of this technique, capsulotomy, that is centered capsular rhexis, is useful for effective lens position. It reduces rate of tilt, decentration, any optical aberration, and hence oblique astigmatism as well as higher order aberration. Lens fragmentation and liquefaction is also taken care by the flax because it softens the cataract and aids liquefaction more in the cube grid form of laser application as already mentioned. Endothelial cell loss as has been implicated from the beginning because it reduces the phaco energy and as well as the time and the need of the fluid. So the refractive outcome combined because of the effective lens position, the reduction in phaco energy as well as time, it increases the refractive outcome as well as the predictability because of the better wound healing as well. So in literature, as you can see, the various authors as well as the trials like FEMCAT and FAT trial, small pupil is just a part of a larger group of sample of patients. There are few case reports where they have also used this flax technique in cases of small pupils like 3.5 also, where they have used hooks. They have cut the extra length of the hook so that the hook does not touch the docking surface. So that is because the pupil size was 3.5 mm. Also there was a technique by authors like, they also used double docking technique, but here they used malunion ring, M rings. What they did is they inserted the malunion after doing the first docking and then they carried out the nucleotomy part. A similar thing was done by a German group of people where they did this 3-step in 40 patients and they got a very good result. So pupil size alteration during femto is very minimal. This decrease is mainly correlated with the length of time it took to use the laser to fragment the lens and the distance between the pupil margin and the capsulotomy, which can very well be manipulated as per the customized as per the individual need. Thank you.
Just a point for discussion, like normally after we do the nucleotomy or whatever the lens procedure, what is the usual time mean before which we need to shift and start the case? Does it really, for example, for some reason we delayed for a half an hour or 45
Yes,
minutes?
sir. That's why I mentioned that we have calculated the transfer time also. And here for the study, the transfer time included the time we took for the examination for specular as well as anterior. So if we reduce that time, it's only like 10 minutes. If you just have to, one will be doing femto, other will be doing OT. So it will be very fast. It won't it won't eat up much of your time, OT time.
And what about the inflammation part? Sometimes it's not just the pupil, sometimes the intraocular pressure goes up, sometimes the eyes become little, they start developing some kind of a discomfort if there's too much of time for some reason.
Yes.
So I think it's not just the pupil, it's also the
So
patient.
that's why I discussed about this pupil size alteration. If you, the more the iris is touched upon, more the iris is damaged or irritated, cytokines are like produced more. The inflammatory cytokines are released more by the iris tissues. So if you do the femto and immediately transfer the patient to the OT, it hardly takes 10 minutes. In that 10 minutes, the pupil size is maintained, cytokine level won't rise to that level that the patient will feel any pain.
I can see an order fed from the master here. Can we get a hand microphone? दीजिएगा आप?
Okay, first we'll ask him what is your normal routine? What is the standard plan for the transfer? And if you're using Zimmer, is it done in the same theater?
He has it in the same OT actually.
3 minutes?
Same theater.
It's
Everything will prepare. Everything prepare before LASIK docking, and just move the patient to this.
So you have the flax machine inside the OT. All right.
we use
Another thing, if you permit me, our average is 100 cases per month. So what?
100 flax per month.
Per month. See, small pupils are regular, and they insist more than the wider people.
I mean the patients insist.
That's the usual
try,
case.
You try. They are force us to try. So what we do is.
And who tells them they have a small pupil?
We tell.
You do,
Is
okay.
it difficult? No, you try, sir. Why not?
Okay.
That is the tendency of our people. Do the two stages? No, same table. We do the side entry. Do the side entry. We put a BX ring.
And then doc.
Then down. So some cases with the methyl cellulose inside, some cases we wash the methyl cellulose and put the saline. BSS and down. Which machine?
That's what my question was.
Catalyst. 2016 we purchased.
You apply the laser with the methyl cellulose inside the eye?
Yeah. And you have to increase the parameters of the retina.
That's what, I mean, that's the reason I was asking. You have to significantly increase it.
Yeah.
Yes, sir.
one of the disadvantages of flax is that the pupil comes down. It comes down in 30 seconds. So even if you're going to shift the patient after 3 minutes, you still have a small pupil, but the capsulotomy is already done. You can preempt this by using NSAIDs. It makes a difference if you use NSAIDs. And the discomfort is mainly because of dry eye, because you put anesthetic drops before doing the flax, and then sometimes the eye is kept open, or the patient has opened his eye, there's no blink reflex, eye becomes dry, and the amount of dry eye post-op is more, discomfort is more. So immediately after doing the femto, just put in some visco, close the lid, ask the patient to keep the eye closed. These are all small things, but it makes a big difference. And we have the Z8 and the Lensar in the same OT, so it takes like about less than a minute to shift them after the flax to the, and I do 100% flax. Yes, if you have a small pupil, then you can put in a Maligan ring, you can put in a BX ring, but then again, there is a risk. If you make for a Maligan ring, you have to put it through the main incision. For the BX, you can put it through the side, but if your wound construction is not very good, if you raise the pressure, there's a chance of leakage. The other thing is the visco itself. Sometimes there are some small bubbles in the visco, they block the energy. You can have tags. Putting in the ring and then after that docking, once you put in the ring, it kind of indents on the anterior capsule, shifts the plane so that the anterior capsule is not uniform. So you have to increase the depth, and even with that you can have tags. So it's not that you have promised the patient flax and you have to do a capsulotomy. If you have promised flax, you can do the arcuate incisions. If he has some astigmatism 0.5, 0.75, you do an arcuate incision. You can do the main incision. But you know why? If you feel that doing a manual rexus is better, putting a ring, doing a manual rexus is better, then go ahead with it. Use the femto for other steps if you promise the patient. I don't cut the nucleus because I do a direct chop. I have found that the difference, anyway, even if it cuts the nucleus, it's not going to cut it through and through. In a hard cataract, you have a plate which does not crack, the posterior epinuclear plate. So you have to go in, you have to bury, you have to chop. The amount of phaco energy difference, same energies, less than.
There is a 86% reduction of energy, but in my practice, I have seen it's hardly matters 5-6%.
Plus, yeah, it's less than 5%. Plus, for very hard cataracts, I prefer to use the Maligan ring because you have a through and through cut, and there's less energy. I mean, sorry, the MyLoop, because it has a through and through cut, and you have no energy in the eye, and it does a better job. Plus, if you make a lot of incisions, the cylinder or the small cubes, the patient is unable to fix. You're not able to see the rexus margins because your red glow is distorted. You can't see the small tags, and if you kind of try to just think it's free floating and pull it, you will have a runoff. You can even have a nucleus drop if you have a runoff. So I don't like to do nucleotomies because they're like half and half. They don't really provide that much of benefit if you're doing a direct chop. If you do the softening with the small cubes in a hard cataract, then sometimes you have some of these cubes go under the iris and get stuck there, and first day you see them nicely in the antechamber, and you have to tell the patient that I'm going to take you up again.
There's something I forgot.
Yeah. So these are, yeah. So I left behind a piece of your cataract, I need to remove it. So these are all issues which are there. So you should know when to use it, when not to use it, and then if you actually do too many incisions under topical, the patient is not able to see the light properly. There's too much of scatter, they don't fix properly. So these are all issues which can be there, and the benefit is not much. You don't save on energy. For soft cataracts, yes, because for soft cataracts, those in between cataracts, the too soft, you can aspirate. But if it's like the neither here nor there cataracts that Ron calls it, for these grade 2 plus, then you can do 4 quadrants, and then I do the visco chop technique. We have published it. I just put in viscoelastic, and then it kind of separates and splits the posterior. So you can do a one-hand technique. It's very easy to remove the nucleus.
No, just a question. Like,
just before we proceed, I would request my co-instructor Supriya and Arupda to come in off the chairs, please.
what is
And
the
the reason
minimum,
why,
minimum rexis, femtorexis that you have done, like pupil, let's say 4 millimeters or 4.2 or 4.5. Will you still do a 4 millimeter rexis, do the phaco and then enlarge?
You can do a double rexis, but it does not serve any purpose. So if it's an intumescent cataract, then yes, double rexis is justified. But in a regular cataract, doing a double rexis, you can as well put in a ring and then do a nice job in the first go.
That's
so
right.
Just because you promised the patient that you will do and take you can do the other steps.
And in any case, I think when you are keeping any wound open, the side port or the main port, and then you are taking the patient back for docking inside the OT. It will only be possible, it's something that we only should try if it's a liquid docking mechanism like the Catalyst or the Z8. It should not be done with the Lens X because it's a solid docking, it flattens the cornea considerably, and there will be a communication for sure. So I don't think we should even think about it, we should even try it.
So in spite of all these points that were discussed, why is your practice 100% flax?
Yes, because what happens is we have a Lean Six Sigma project where we continuously monitor outcomes, and we looked at the flax and the non-flax groups. The difference in accuracy of refractive correction is about 8 to 10%. So 8 to 10% of patients in the flax group were within half a diopter, more than the non-flax groups. This is because, of course, you're doing a perfect capsulotomy, you get a very good centration of the lens, plus you're using your astigmatic incisions for small amounts of astigmatism, which kind of bring down the spherical equivalent. So the outcomes, yes, they are marginally better. I would say about 8 to 10% better, and it kind of, the other advantages is if you're using a femto lens like the femtis lens, you need to have a femtosecond perfect rexis for fixation. So these are all some of the reasons why I prefer to use flax, but I use some steps, I don't use the others. And
But sir, looking at
that
your
means,
volume of practice, I don't think 10% is marginal. It would be in
yes,
absolute numbers.
yes,
it would be huge.
it is a big number that increases patient satisfaction, because when they come for a premium surgery, you're using a premium lens, you want to be within half a diopter spherical equivalent. The multifocals and all that, they work best if you're within half a diopter spherical equivalent.
Right.
So your flax, preferring flax, what is the main reason? The main reason is the rexis.
Yeah, the main reason I use it is the rexis, and sometimes the astigmatic.
Do you use a corneal incision with the flax?
Corneal incisions, I have tried. With the other platforms, it's terrible. You have to dissect it. There's not much of advantage. You have to be clear corneal. With the Z8, you can be limbal because it has a corneal module. You can do keratoplasty, you can do clear and all that. So the incisions are just like a blade. You can just go in with your cannula. You don't have to actually dissect and open the incisions. So with the Z8, yes, sometimes I use the incisions, but again, the incisions do not make that much of a difference when you compare it with your blade. If your blade is good, I use money blade, so it's almost the same. I look at it on the intraop OCT. The wound configuration also is pretty good. So, but probably the rexis makes a big difference. Nucleotomy again doesn't make a very big difference. In soft cataracts, yes, for the viscochop technique, it makes a difference.
So I have one question to you. You are shifted to 100% flax. So it's a flax and surgery by the same surgeon. It's a two surgeon combination.
It's like yes, the optom, the
Because
laser tech.
as your volume, if
So
you
that is what I wanted to bring out as a point. You listen to the flow chart of his OT. It'll be very interesting.
So
Yes, sir.
I have three tables which kind of move. So I have the laser, and then I have the 3D microscope I'm operating. The laser is done by the laser tech, but it is verified and finally approved by my fellow.
Okay.
Okay, so then the laser is done, standard fixed parameters. If I want to change anything, I've already instructed it pre-op, is done. Then the preparation happens. There's the OT assistant who prepares, and then it comes to me. So I'm able to do about 15 cases an hour. In fact, I can show you in time lapse also how it happens. So flax does not
We
actually
have
reduce
been
the time.
tired of clapping for him, sir.
No, it does not actually reduce your time. It can improve efficiency, and then you have a perfect rexis most of the times. But there are some conditions where you have to be very careful. You know, when there are any corneal scars, post-RK, corneal scars. If you have had silicone oil post-vitrectomy, you have some of those small bubbles come in, they can block. Gutte, now sometimes you take a case of Fuchs saying that, okay, the amount of energy you use is less if you do nucleotomy. But the gutte itself, if they're big, they actually block the laser, and then you don't get a good rexis. So you should be aware of all these situations and the problems that can happen and how to overcome it.
And in case of, in the presence of corneal gutte, I believe the threshold we have for the energy use actually should come down significantly, because the laser energy, when it is being delivered into the eye, the endothelium does not have a protection of viscoelastic. So that's something we have to keep in mind. So the threshold, the energy level where we wish to be, has to come down ultimately. So that's something we need to calculate.
And it takes much more energy to do the nucleotomy than the capsulotomy.
Excellent discussion. Thank